So you may wonder why I'm standing up here when there are all these authors ahead of me on the list. Well, as you can see, we have two bumps, one here and one here. And about a week ago, they were transformed into healthy male infants, both of them. They were actually laboring in adjacent rooms for a while. So sadly, neither Katie nor Shannon could make it. Jean is already overloaded. Derek's already overloaded. So they said, will you talk? Oh, all right. So here I am. We work with lots of filler companies, and I'm not going to be talking a lot about specific products. So I don't think that there are any more disclosures, but I'm certainly going to be talking about non-FDA approved things. Why are filler complications increasing? And I think that there are a number of reasons. Firstly, there's an increase in the number of filler treatments. Secondly, we've moved from a two-dimensional approach to a three-dimensional approach, which means that we're injecting deeper. And guess what there is deeper? There's all those named anatomic structures, in particular the vessels. Gosh, it's difficult to see that screen, isn't it? Is the skill of the injectors keeping pace? And that's a question that I'm going to ask you, because in the still of the night, you'll be asking it of yourself. Can I ask, who in the room injects fillers? Pretty much all of you. Who in the room has had a vascular occlusion phenomenon? Don't mean blindness, I mean immediate blanching, or something that tells you that. So it's not unusual to get these things. We're not talking about something that's very rare, unlike blindness, happily. So we collected our data on what is happening in our office with regards to vascular compromise, and God, I must be getting old.
Can you see this one?
No, not really.
You want to try my glasses?
Anyway, we collected 10 years of data. We had 12 cases of vascular compromise, 8 in our clinical practice, 4 due to an experimental particulate filler. And the management of them varied, so we really didn't look at that. We had an incidence of 0.27 with Radiesse, with calcium hydroxylapatite, which was 3 times the 0.09 that we had with, I call Voluma VHA, I hope that, and just, great, yeah, now I can see the damn thing. Thank you. And of interest, one patient was treated with both, and so we included that patient in both up here. So if you'll see it adds up to 9, and we only had, I said we had 8. Can you see? I can't. I think, is it this side? Which is the... Turn the lights down a bit, could you? That would be helpful. You can see the very characteristic reticulate pigmentation or pattern on the vessels that we see with some of the more subtle vascular occlusion things. So this is what you typically would see an hour or 2 after injection, not having seen any immediate blanching. This, on the other hand, is what you see when you see more immediate and more significant effects. And this was a hydroxylapatite individual. And she did not blanch when I injected her. And she showed up 2 weeks later looking like this. Absolutely terrifying. But happily, you can see that she healed really well. There's one myelium there, but otherwise, and a little bit of pigment change, but she healed remarkably well considering how awful she looks here. So that's background. Now we started looking at and thinking about blindness, because I mean, if what I've just shown you is the worst that you're likely to get and it's likely to heal up, well, you know, let's not worry too much. But if you're going to cause blindness, then this is serious. And this is a paper that was in Derm Surgery very recently. A literature review up to this year in the English language literature. Katie did this, and she said that one of the big problems was that most of these cases are reported by the rescuing physician, not by the perp. Anyway, she found 98 cases of blindness or vision loss due to fillers over a period from 1906 to 2015. But most of the reports are in the last 5 years. And last year, it's estimated there were 5.5 million filler treatments worldwide. So you could say the risk is still very low. But in your practice, one case of blindness is enough, right? That's enough. How does it work? Is it intravascular or perivascular pressure? And I think that this is still under discussion. My personal belief is that it's intravascular, and I'll show you some evidence for that. And what happens is that you happen to get your needle or cannula, or whatever you're using, into a vessel. The material will go backwards along the vessel, and then you stop injecting and you let the pressure off, and the material then, under arterial pressure, will move forward into the smaller vessels and block them. So if you look here, let's say you're injecting the glabella area and you happen to get into the supratrochlear vessel, and the stuff with the pressure of injection will go down here. You stop injecting, and then it gets into the retinal circulation, and you're in trouble. And here's the reason why it's not that easy. This is work from Dr. Kim, who is a Korean anatomist and a great dissector, someone I have great admiration for. And this is the facial artery, and you can see there are all kinds of different patterns of facial artery. And frankly, when you stick a needle in, you've got no idea which this particular individual has. What was the area that was being injected when these individuals had vision loss? And you can see that this area, the glabella and the bridge of the nose, are the main areas, but central face, I don't know what's happening out here in the earlobes.
Not specified.
That was other, okay. Unclassified, oh, okay. Then the sites were principally glabella, as I've said, and the nasal region in general, but declining, as you can see. What was being injected? Autologous fat accounted for approximately half of these cases. And I expect we'll have a discussion with our moderator here about injecting fat and injecting fat safely. Clearly, this fat was not being injected safely. The next most likely is hyaluronic acid, and then other causes significantly less. For some reason, South Korea seems to have the vast majority of cases. Is this because they're particularly good at collecting them? Maybe. Is it because they don't like the bridge of the nose area and they want it augmented, and so they're being injected in a dangerous area? I suspect that that's probably what's going on. but certainly the Koreans have more of a problem than anyone else, so maybe we'll get solutions from them. And you can go through this. You can see the different things. The area that bothers me here are the 23 cases with CNS signs and 1 death, indeed. So we're not talking minor vascular events here. We're talking significant vascular events. Autologous fat, 80% of the individuals who had vision loss with autologous fat had complete vision loss in the affected eye. And 19 of the 23 cases that had CNS problems were associated with fat injection. Hyaluronic acid, about 40% had complete vision loss, and there were only 2 cases with CNS complications. There were various treatments tried, and I'm not going to spend any time on that. Prevention. Number 1, know the anatomy, be aware of it. Number 2, inject slowly and with little pressure. I think this is very important. Use small increments. I'm not sure about moving the needle tip while you're injecting, because if you're moving the needle tip, then you can't, you're unlikely anyway to be aspirating every time you move it. And I think it's better to find a safe spot and leave it alone, but that's my own personal preference, and that's controversial. And then using small needles, cannulas, syringes, and some people favor cannulas, some people favor needles. Jean only uses needles, won't use a cannula. I tend to use cannulas whenever I notice my pulse rate rising. So then we went on and published this paper, which was in PRS last fall, and looking at what happens when it happens. You have maximum 90 minutes, maximum. I'll come back to that. So you need to have your ideally an oculoplastic surgeon who's close by, but an ophthalmologist, someone who can help you out close and on speed dial. Do not send the patient to emergency. You have to be holding this individual's hand for at least until the 90 minutes has gone by and you're hooped, but preferably beyond that. And we're going to talk a little bit about flooding the orbits with hyaluronidase. This is a paper from the Korean literature, just to show you what can happen. Guy goes to visit a dermatologist, wants his nose improved, and ends up with this. You can see there's a huge area of necrosis. He's got lagophthalmus on this side, and his eye movements are abnormal or missing on the right. This is hypopion, which means that it could be white cells, or it could be radiesse, which is the material that was injected in this individual. But there is certainly radiesse beads present in some of the conjunctival vessels here. So at least in this individual, we know for a certainty that the material was intravascular. This is not external pressure. But he actually ended up not too badly. A little bit of eyelid droop, and his vision in that eye was, I think, 20/40, or it probably tells you up here, I can't read it. So even in a situation where you've had a real disaster, if you're lucky, things can turn out not too badly. I heard about this case in Belgium. I'm sure many of you will know Koen de Boel. And a dermatologist in Belgium called Koen because the patient he was injecting had just lost the sight in one eye associated with excruciating pain. The individual was being injected with Voluma to the midface and Juvederm to the nasolabial fold, and there was unilateral complete vision loss. So Koen did his best to persuade the ocular plastic surgeon who had been called to flood the orbit with hyaluronidase. She objected strongly on the grounds that there was a theoretical risk that you could actually make matters worse by moving the material further into the orbital circulation, increasing the pressure around the globe. And, but eventually they did manage to inject 1,000 units of, I think, Hylase under general anesthesia at 60 minutes after the... So it's not bad. It's roughly within the 90 minutes that we expect. And this individual achieved 10% return of vision after day 3, which is not unexpected for an HA vascular occlusion. So whether the hyaluronidase had any effect here, I don't know. I would have to say, in all honesty, I don't think it did. But maybe this 60 minutes is too much, and we really need to be getting active earlier. Having said that, I'm going to show you a retrobulbar injection, and like it or not, if you're injecting, you're going to have to practice this. So this is a woman who came in for another eye procedure, and these are the hands of the head of ophthalmology in Vancouver. Ophthalmologists like to do things without gloves. I accept that. Don't worry about it. Well, there's other more important points here. And the spot he's aiming for here is midway between the mid-pupillary line and the lateral canthus, just down there. And what he's doing is putting the needle in about 9 millimeters below the lash margin. And if you go straight in, you'll feel the bone. Very reassuring. If you're touching bone, you're not touching the globe. And then you angle the needle upwards a little bit, and you can go ahead and get a full inch in. You need to be an inch in. And you can see he's wiggling the needle about a bit in order to make certain that he hasn't speared the globe. What happens if you spear the globe? Doesn't matter. You've got a blind eye anyway. So don't worry about it. Just go ahead and do it. Get a syringe full, and ideally up to 1,000 units of hyaluronidase. We can arrange that this video is available. It's in the journal. So you should be able to practice that, not practice, but at least read it up and know what it is that you've got to do when it happens. How?
What about draining the anterior chamber?
Good question. The concept is that you take a Graphie knife, and having a dermatologist wandering around waving Graphie, but you're right again, because this is a blind eye, and you spear the chamber from the side, drain the fluid out of the anterior chamber, drop the pressure, and hope that what that'll do is to move the blockage more peripherally in the retina. There are other techniques you can use as well, using mannitol and so on and so forth. I just want to show one thing. There's a Munson's view. Oh, we're going to see the whole thing all over again. Anyone want to see it again? No. Because this is what you need to know. This is the take-home message. Kevin?
Alistair, there are some great videos on YouTube explaining this with diagrams. You can learn it from several different points of view, so I would suggest everybody look it up on YouTube and review it.
Great idea. Great suggestion. You see... Yeah, well, that's what this ophthalmologist is doing in order to get anesthesia. But, and I'll show you the proptosis. I mean, it's not huge, but it's definitely there. It's going to depend on how much fluid you put in with your 1,000 units. Let's just see if, I think we're going to the Munson's view in a second or so. He puts a little bit of pressure on and a bit of gentle massage just to move it around inside the orbit. Isn't it funny seeing someone not using gloves? Okay, I think we're going to look at from above now. There you are. And you can see this eye is further forward than this eye, I hope. Can you? Good. I'll stop. Thank you.
Well, fat's certainly less scary than that. No eye pictures on this one, so squeamish people don't need to leave the room. Disclosure is not directly relevant to this because it's basically in the realm of fat. I am an investigator for neophthetics and in the Speakers Bureau for Kythera. So I think that generally in the non-invasive body contouring, non-invasive lipolysis world, the most controversial part is who to use it on, when and why, and how beneficial they are. The differences between the treatments, and is one better than the other, I think it really depends on the patient itself rather than this device is the best for everybody. Every device has its advantages and disadvantages. The more controversial part is what's the future of body contouring? Is tumescent liposuction in general going away? I don't think so. Looking at trend data, it seems like liposuction's been pretty steady over the last decade, even though we've had this explosion over the last 5 years in non-invasive lipolysis. The interesting trend is that the non-invasive is sort of expanding the market, and I've seen that on our end is that there are more patients coming in asking about it because there are non-invasive options. So the market is broadening, not sort of limiting. So I think that's an exciting part for people that are doing body contouring. In fact, from our own ASDS survey, you can see as we have an expanding waistline in our population, more people are bothered by fat. Upwards of 86% are bothered by weight, 67% on the chin, and over half of the population surveyed was considering body contouring. Now, of those people, how many come in the door? The more options that are available, the less invasive these things are. We know people are going to come that way. You can also see from our ASDS procedure survey how many of these procedures are done. And if you look at this over the last few years, as more of these devices become available, these numbers have expanded. And so that's where I really think it's happening, is we're expanding the market rather than taking away from liposuction. So those of you who do liposuction, don't worry too much. First, talk about cryolipolysis, something we've had for 5 years, and I'm sure a lot of people in this room have heard about, have experience doing. It's really exploded, I think, from the one standpoint in that no operator is needed. Good and bad. So not only is it in our offices, it's in esthetician offices, spa offices, down the street in your hairdressers, all these kind of places. So that's the disadvantage to our specialty. But these are simple treatments. They're hour-long. Patients can do this really simply, can work, can read their email, watch movies. It's in a suction-assisted cooling, so the device creates suction, which pulls the fat into the applicator. I'll show you a few of the applicators in a second, which then freezes the fat and causes fat cell lysis and apoptosis, leading to paniculitis and then tissue contraction. There's a consumable cost per cycle on these. There's a limit on what you can charge as well. So the devices here, you can see multiple of the different tips, different sizes, and this is not all of them. Recently added a neck tip that I'll show you in a minute. So trying to fit different body parts and body types. And that's really the part about selection for this device that's most important, is fitting the right person to the suction. Not everybody is the best candidate for this. If all you have is a cool sculpting, your population is limited. If you have multiple different options, you can treat all of these different patients. Obviously, that's not feasible in every office. Talked about the apoptosis leading to decreased fatty layer. It's been more or less in some papers. I think it's highly, highly patient dependent. If you have someone that comes in and has a very thick fatty layer, very fibrous tissue, they're not going to get the same response. Do you have that someone has soft, doughy tissue, they can get more contact with the device? There's no damage to the dermis and epidermis. We've seen that sort of over and over again, no nerve issues whatsoever. There are some sequelae possible from it that we'll go over in a minute. But generally, treatments, multiple tips are necessary. There are very few people that can come in, do one treatment, 1 hour in a cool sculpting, and get an adequate result. It's not comparable to tumescent liposuction. It's something that most people have to sort of be prepped for in advance. You're going to need to come in multiple times. You're going to need multiple treatments. So that helps in your patient selection. If they think this is the one size fits all, this is the magic bullet, nothing is, right? Repeat treatment, on sites are generally done in a month. And so we used to space that farther apart, but we found that safe and sort of doubles down on the effects, that people get better results doing it that way. It's also been studied that you can do a partial overlap of treatments, especially in the flank area. That's helpful in men. So doing sort of part of the anterior and part of the posterior, you can get more results instantaneously rather than waiting a month and retreating the same site. Compression is not necessary. So unlike going through a surgical procedure where you're in compression for 4, 6, 8 weeks, people can go back to their normal life. They can go back to their exercising. They can go swimming. They can do everything. So from a patient's perspective, this is great. Compression can be helpful, though, in patients in managing some of the sort of post-op sequelae, the edema, the pain associated with it. It's sometimes helpful. And we actually advise our patients for 2 or 3 days to wear compression. Post-treatment massage has been studied, and that does seem to affect the improvement. Some people have actually also recommended using a sort of ultrasound device to improve that. But we know that massaging the area directly after treatment does improve the treatment results. Patient selection, who's the best candidate for this? And I think the most important thing is make sure they know what they're getting into. Make sure they're committed. Multiple sessions. They're going to maintain their diet. This is not for the yo-yo dyer. This is not for the obese. This is for the person that's fit, that's looking to reduce, but doesn't need as much sculpting or as much fat reduction as liposuction, or is unwilling to go through that. They need mobile skin. So if you have someone who comes in who's really fit, really thin, and doesn't have mobility of their skin, this is not for them. The suction has to be able to pull that tissue in to get a good result. And I'll show you a negative side effect of that in a minute. The opposite is also true. If someone has really fibrous tissue, really thick fat, that they're not going to get any contraction into the applicator, there's not going to be any benefit. So this is really for that middle of the ground people that are sort of slightly overweight, not too overweight, but also not too thin. Laxity is okay, and this is something that was produced out of the Carruthers group, is that they do show some contraction. And I've seen that extensively in my practice, and I actually prefer it for people that have laxity to do this device because of the retraction it gets. I'd much rather do this than liposuction on someone who's got some serious laxity, because once I take out that deficit, they have to recover that in the body. But because this is an inflammatory over time process, they do get some tissue contraction. They also need to have realistic expectations, and you really need to coach that on anybody, just like we do anything aesthetic. Who to avoid? Too thin. And this is a patient actually from our office who the rep put in there, really, really thin, marathon runner, tried to shove the skin into the applicator, and this is what she got. It's hard to see in this part here, but there's a little dent there. I actually had to go back, do liposuction on her. I had to find a place to get fat on her, which was difficult, to fill that deficit, and it took several times to get it to be perfect again. But that was somebody who just, you would think is the perfect candidate for it, but you really got to know what you're treating. You're treating fat, not skin. They can't be too thick, like we've already said. Hernias, there's been one report to the FDA of potential of this causing a hernia. I would not treat this in anybody who has a hernia. You could potentially make this worse. You could potentially incarcerate it. Really do a physical exam on these patients, and that's what I worry most about when people go to spas, hairdressers to get this treatment done. They're not getting a doctor to get a physical exam. Recent scarring, someone's had a laparoscopic procedure. I would avoid that tissue until that tissue is mature. I don't have any data on that. It's just smart sense. Locations, and this has expanded tremendously over the past few years with the different applicators. These are all the possibilities. Basically covers everything except for the calves, probably. The newest applicator is the Mini that covers the neck. We don't have a ton of experience with that. But the most important thing is fitting the applicator to the area. The inner thigh is not a curved area. You can't use a curved tip. The abdomen is not a flat area. You can't use a flat tip. So everybody's a little bit different, and so having experience with what tissue goes with what is very important. This is a patient of mine, would have done better with liposuction, didn't want it, was willing to go through multiple sessions. I'll show you we did a large tip at the lower stomach. We did 2 diagonal tips with the smaller on the upper. And a month later she came back, she's better. And then we went ahead and did 5 tips at different angles to get the rest of her adipose. And this is her at a month after that. So pretty good results. Not a liposuction result, but for a non-invasive treatment, it's a good result. Problem with this is this costs a lot more than doing a liposuction procedure, but patient didn't have downtime, didn't want to wear compression, didn't want to go about her life. So this is something you really need to explain to patients. There's limits to what non-invasive technology can do, and there's costs to doing these things as well, so you have to find that patient balance. This kind of goes back to the point about laxity. This is a patient of mine who came in for liposuction, and I didn't want to touch him. This guy, obviously, I think more and better would do better with an abdominoplasty. He's got a serious pannus. If I could suction him and improve it, but then he'd have a flattening of the area, it wouldn't be much better. So he came in, we did a large tip on the lower stomach, we did 2 tips horizontally, and then a curved tip on the sides, and that's his result at a month after that. Pretty good tissue contraction. You'll see it better from the side. So taking that fat away, allowing that tissue to contract, I couldn't do that with liposuction. I could keep the guy in compression for 3 months. I don't think he'd get that kind of results. He had such significant laxity. So that's where I think this makes a really big difference in people that have laxity. Sequela, suction-related pain. This is mostly around the umbilicus, especially above it. Some people can't tolerate it. Around the other areas, it's usually not too bad. Intense cold leads to numbness, so most people after 5 minutes are really tolerable, watching a movie, reading a book, doing work, on conference calls. Afterwards is really the thing you have to warn people about. They're going to have some edema. They could have some bruising for a while from the suction. They're going to have some numbness, which generally goes with the edema, so 4 to 6 weeks. Tender to the touch, so their kids jumping on them, they have to be warned about that. Abdominal cramping, especially people that treat around the umbilicus, people that have had abdominal surgery way in the past tend to get more of this, so they need to be warned about that. Sometimes people do need narcotic pain medicine. I know people have talked about using some of the neurologic agents, Neurontin, Lyrica. I don't find it helps. It's usually a short-lived thing. We'll give them muscle relaxers, but it has to be warned on people that can do abdominal work on. And then no effect on circulating cholesterol levels. We see that with all of our non-invasive devices at this point, so that's a good thing. And then the most dangerous side effect from this that we've seen is this paradoxical adipose tissue hyperplasia. It's rare. I think the number that's been quoted is probably rare, just like with the blindness literature. People that are doing this are not reporting this probably every day, unless you're seeing it from another site, not from the perpetrator, as Alistair said. So there's probably more of this, but again, you need to know it is rare. I've seen it once, not from our site, but from someone else. The treatment of choice is generally liposuction or abdominoplasty if it's on the stomach. I would not retreat these people with the same device. You could theoretically use another device. The mechanism is really unknown at this point. There's been theories that it's a fibroblastic response to it. It's a delayed reactive response, but then there have been other reports that there's really no tissue hyperplasia other than fat. So it's still an unknown entity at this point. I'll mention a little bit ultrasound. So high frequency ultrasound we'll talk about first. I don't have a lot of experience with, but just for completeness sake, this is the device, the Liposonics device, which we've had for about 4 years. It's operator dependent, unlike the cool sculpting. It's got a focal depth of 1.3 centimeters. The nice thing about this, other than a treatment tip, is it's customizable. It's got a handpiece, so you can move it where you want it. How does it work? It's high temperature, so it's a coagulative necrosis mixed with cavitation, tissue temperatures of 50 degrees or more. So the bad thing about that is it leads to pain, and that's been the big sort of barrier to this treatment in non-invasive technologies. It's really painful to most patients. There's no change in laboratory values, just like with the cool sculpting. Single treatments, they can be repeated, but usually have to be delayed until the swelling goes away, which can be sometimes 6, 8, 12 weeks. It's more customizable than the Zeltique because you have a handpiece. The operator can decide you can do a small area, you can do a big area, you can treat different angles. It doesn't have to be a perfectly flush area. You can treat multiple areas. You can skip areas, so that's the nice thing about it. Results are delayed. It's about 8 to 12 weeks from the process, waiting for the swelling to go away, waiting for the tissue contraction. Patient selection, these are thinner patients. It's limited by its depth. Now, there's some contraction beyond that depth because the heat diffuses around that tissue a little bit, but 1.3 centimeters is not that deep. So you get someone who's obese, this is going to do very little. They can have some mild laxity because of the heat. You're going to get some fibroplasia. You're going to get some tissue contraction. They have to be really pain tolerant, or you have to have ways to control that because that's something that most people complain of is significant heat. Post-procedure, they have a lot of edema. They can have bruising. Just like with the cool sculpting, they can have numbness. They can have nodularity. It's a very similar process from paniculitis. And then the non-thermal ultrasound, very similar, so operator-driven, handpiece-driven. It's been around for about a year in the United States, much longer abroad, up to 10 years. The focal depth similar, 1.2 to 1.5 on the newer handpiece. So it's a little deeper, a little broader range, but there's no heat. They say there's no heat. There's probably a little bit of heat. Treatment time's up to 45 minutes, but customizable just like the previous device. So cavitation mainly affects, there's probably some heat and some warming, as most patients complain of some of that, but not to the same degree as we see with the previous. So it's really a very comfortable treatment. The nice thing, we see intact nerves and vessels, and that's been studied on histological settings. There are generally 3 treatments, 2 weeks apart. You could do more, you could do less. Again, it depends on the patient, the customizable. The biggest barrier for me is the tracking system. As someone who knows 3D contouring, it's really hard to have to listen to a computer to tell me where to go. I'd much rather do it by myself. But it does help control avoidance of retreating areas, bony injuries. So the machine does help to avoid those sort of dummy errors that some people can make. There's potential for reflection injury. That's why, to avoid the bony areas, can cause some blisters, and that's been reported. Circumferential reduction has varied, and I think that's you see a wide variance because of patient selection. If you take someone who's obese, you're going to get very minimal. Take someone who's thin, you're going to get very minimal. So it really kind of depends on the patient more than anything. These are thin patients, just like with the previous device. So these are the really thin patients, the people that you can't fit into a cool sculpting. Even the thicker patients that need some reduction, some softening before you could do some cool sculpting, you could do this as well. They need good skin quality. You're not going to get tissue contraction with this. There's no heat. There's really no paniculitis. It's more of a cavitation effect. This is for people that are pain averse. Can't do surgery, can't see a needle, can't have pain, can't have anything. I have a couple lawyers that got to be in court every day, and this was perfect for them. Treatment of choice for thin areas, it's areas that you can't get to with other things. Top of the knees, ankles, works well in those areas. Sequela, generally none. This is one of the main ones, which is a blister, and this is from incomplete contact on the skin. Over bony areas, you can get blistering as well. And then tissue irregularities, because it's operator-driven, obviously you can cause denting in certain areas if you retreat areas and skip areas. So it's really important to sort of have someone who knows how to operate the system. This is a patient a month after 3 treatments, so she was thin to start with. Pretty good result. Again, you could probably do better with tumescent liposuction, but pretty good result. This is another patient that's just 3 months after 3 treatments. Sorry for the shading on that one. It was a bad picture there. But she's very thin to start with. Make a big difference in these people. If you did this on some of the patients we showed with cool sculpting, you probably would get minimal results. So comparing and contrasting them, the cool sculpting patients are a little bit bigger. The ultrasound lipolysis patients are a little smaller. As the cool sculpting is limited by applicator for where you pick, the ultrasound are a little more flexible in what you can do, but they're limited by their depth. The cool sculpting works through cold paniculitis, ultrashape through cavitation, and liposonics through cavitation through heat. As far as pain, liposonics being the most painful, followed by the cool sculpting, followed by the ultrashape. Post-op sequela we've talked about, and then the operator is the big difference. And then obviously the heat and cool shows some skin tightening, whereas the ultrashape shows very, very little, if any. This was a study that was recently published that was comparing the two just to make it more confusing. Showed almost no difference statistically between ultrasonic and cryolipolysis groups when they were maintained on a diet. Both groups showed a better improvement than diet alone. And then make it even more confusing, how about both? This was a patient who I was getting married in a month and wanted to do something quick. I didn't have a lot that I could do quick, couldn't do liposuction, couldn't just do cool sculpting, so we did both. So we did a ultrashape on the full abdomen and a cool sculpting on the lower abdomen, and this was her at 3 weeks. So I don't know that anything else can do that in 3 weeks. And so in summary, there's high patient demand. It's expanding the market. The most important thing you can do is properly prep your patients for their expectations, select them for the right device, the right applicator, the right treatment regimen. None of these are going to replace tumescent liposuction in the near future. And then optimization, better devices, more devices, better protocols. We're only going to see better results.
Before I introduce the next speaker, I just want to say thank you to Bill for really putting all of this together. These were his ideas, and it's been a fabulous session so far. Our next speaker is known to all. She's a great dermatologic and cosmetic surgeon, and you'll know her maybe most closely this year as our incoming president, and I think we should give her a round of applause for taking this on. She's going to be talking about fat versus commercial fillers for volumization.
Hey, good afternoon. Is this is the advance? Got it. So I'm not sure anybody even likes fat anymore, but I'm going to try to change your mind because I think fat has a role. So let's go over this. I have no relevant financial disclosures. Fat isn't even pretty, is it? So what are the fat pros? Well, certainly in this gentleman, it's available in large quantities. There are no issues of biocompatibility. It can be complementary to liposuction. If somebody's already planning on getting it, why not put the fat someplace? And it's certainly more cost effective if you need a large volume of fill. What are the filler pros? Filler is sexier. It's easier. It's completely titratable, and it's safe, very safe usually. What are the cons? Well, you got to do a harvest to get fat. We all read that article that came out that Alistair talked about very carefully, and it is possible that because it's more particulate, it's a larger particle, that there might be a greater risk of embolus, maybe even a greater risk of infection because there's some processing in the office. And I feel the longevity of fat can be variable. Filler cons, it's really expensive. If you need a lot of it, there's a big price point there that many people won't be able to get enough filler to get the result they need. However, it does have a building effect, but some areas seem to be quite resistant to that building effect. I feel like it builds better in some areas than it does in others. So let's talk a little bit about the history of volumization, because years ago, before 2003 in the United States, all we had was collagen or fat. And they fill very differently. Collagen fills lines, and fat reinflates and volumizes. And so it was very clear which one you used for which thing because they were so different. And then hyaluronic acid fillers came on the market, and of course other fillers subsequently that had much more lifting effect. And so all of a sudden it somewhat muddied the water. And they lasted longer than collagen did. And so that longer duration, the building effect that I just talked about, the fact that you could get more lift per volume of product than you could with something like collagen really changed the whole filling market. If you look, I think the color we're looking at here is the blue. If you look before 2003 on that bar graph, before 2003, fillers, we weren't using that many fillers. And then all of a sudden, the hyaluronic acids came on the market, and boom, we were using a lot more fillers. And then the second graph, you're looking at the red. That's the hyaluronic acid fillers. And again, same time frame. When they came on the market, they just knocked, collagen out of the park. That's the blue. So the problem is, when I looked at doing this talk, there really aren't any great studies that compare fat to filler. No double-blind controlled studies where you're looking at commercial filler on one side or in randomized patients. We just don't have that. Some of the reason is intuitive, I guess. There are baseline patient differences. I always think it's difficult to compare two fillers. It's even difficult to compare two sides because people's bony structure is so different. No one's symmetric. You have to look at them in a three-dimensional fashion. There's great variation in the way people process their fat and use their fat. There are variation in injection techniques, and you really need some long-term follow-up to know, really which one you would prefer in a certain area. So it's not out there, interestingly. And again, most of the fat research is in the facial lipoatrophy associated with antiretroviral therapy. So that's a certain patient population rather than where we use the majority of our fillers. So what happens when somebody walks into my office? How do I decide? Since I do both, and I have the luxury of deciding, how do I decide what I'm going to do? Well, I look at what their goals and preferences are. Do they want body contouring? Then maybe we are going to be more likely to talk about fat transfer. What is their timeline? What is their price point? The other thing I look at is, when I'm looking at their face today, how much volume are they going to need over time? Because that's really sort of what you need to be thinking. Is this somebody who needs greater than 10 cc's of volume, who would really, you're going to put, because most patients, when they come in for filler, are going to get 2 or 3 syringes, and is that not even going to touch what they really need done? Because sometimes when those patients accept filler, they're very unhappy. Then they come back and they get filler again and they're still unhappy. They can take a lot of time. And so maybe they would have been happier had you put more volume in with fat. We've talked about this before. The old approach with fillers was to fill under lines like we do with collagen. But when the hyaluronics came out, all of a sudden, that didn't look so good. People were being very overfilled in the perioral region, and it wasn't a natural appearance. So guess what? We thought, wait a second, we know how to use something that's more robust. Let's use it like fat. And that really also changed the way we use fillers. So that's kind of blurred the line between the two. I actually fill with injectables very much like I've always filled with fat. And we lift. So here are just, some places where we do lifting, and this is all, I'm going to show you a series of pictures that could be filler or fat. It wouldn't matter because we're really doing the same thing. And in some of these areas, fillers last a really long time. So in the temple area, I think a lot of you know, you put a cc or 2 in the temples and that might last a year. This is somebody, again, this is not a fat result. It's Botox and it's botulinum toxin and fillers. Again, not fat. Lifting the lateral brow and temple area. So really, I feel like the line has blurred so much with what we can do with injectable fillers. We do very much like what we do with fat. The issue is, how long-lived is it? And again, that kind of depends on what region you're talking about. I feel like in the upper cheek, tear trough area, it's easily 6 months. In the temple, maybe 9+. But when you get to the nasolabial folds or commissure in the lips, it's much more short-lived. But then honestly, I think fat's more short-lived there too because of the movement. So let's talk a little bit about the building effect. Now here's a guy who I had great building effect. Here he is at baseline, and there he is 4.5 years later before he gets his filler. And I'm not filling him anymore in the areas that I started filling him in. So not every patient has this kind of result, but it's not uncommon. So now let's move to fat and sort of concentrate on that process, because I've now established that the line, or why you use them, is somewhat blurred. So again, remember, fat available in large quantities in most people. A lot of people like the idea because it's biocompatible, complementary to lipo. It can be very cost effective if you're using large quantities. I still think, though, that the results are less predictable for me. I sometimes have somebody who just augments better with fat. They hold on to their fat better. And I'm a pretty experienced fat injector. And then I'll have somebody else who, after a year, I feel like everything I put in was gone. And I'm not sure why that is. Maybe some of our experts can shed some light on that. But that's what I find in my hands. It's got a lot of steps. It's a commitment to be more surgical, fat is. You got to harvest it. I agree completely with Bill that, atraumatic harvest, we'd like to use the outer thigh. Greatest lipogenic activity here. It's relatively avascular. It's a great area to take your fat. We remove we drain the infranatant, we sit them upright, we wash it with lactated ringers to get rid of the debris that we think maybe adds to the breakdown of fat. We centrifuge it. And when we do, let's see, it's not doing what it's supposed to do. Did it do it? It did. Okay, so now the big issue for me is we were very interested in that stromal fraction, and I was doing a lot of work with that. And then the FDA decided that stromal or adipocyte stem cells were a drug. So I feel like they are the future of fat, and yet most of the research that is being done with stromal and adipocyte stem cells is outside of the United States. And I pretty much had to accept that unless I was going to be in this big battle. I think you can leave them in, which is what I do, and that's okay, but you can't just transfer the stromal fraction. We were also breaking it up with collagenase. I can no longer do that because, again, that has to be done within a study protocol, and that's considered manipulation. But I do think that's another thing that is in the future of fat, breaking it up, smaller particles, put it through smaller needles. I'm not a proponent of storing fat. We did a study that showed that there are no viable cells once you freeze it. I know that's controversial. There are people here who would disagree with me about that, but I do my transfers all fresh. This, I think, is a burgeoning area, adding in platelet PRP, adding in things that are going to stimulate the viability, increase stem cell differentiation. There's some interesting studies coming out about where you're putting the fat, whether it's right over a muscle or further up into the fat, what's going to encourage those stem cells to better differentiate and expand the fat. So all of that, again, I follow that research, but it's not, you can't do it here. This is what I was thinking. Bill is exactly right. We always transfer it into these smaller syringes. Certainly injection pressure plays a role in intravascular introducement, so we don't want to put this into vessels. You want to inject slowly with a small syringe. And we always use a blunt cannula, retrograde fill, and we inject it right now into the subcutaneous fat until that literature changes. This is just sort of an example of how we plan that. And really, these patients, we inject anesthesia into the entrance sites, but the interesting thing is you can basically move a blunt cannula in all of these places, re-put the fat in, and you don't need any other anesthesia. And I think that she has a moderately good result. We still have some work that we could do. This is an excellent result that was given to me by Lisa. I will say, though, that to me, where I'm using fat more is off the face, because really the volumes you need there are so much greater. And not so much for the hand, although we have some nice results with the hand. This is a nice softening. I think you can probably get this with Radiesse as well. But where I'm really seeing that I'm using it, and I just happen to be starting to collect these cases, are these people who are getting depressions over the trochanter from from steroid injections into the bursitis that they get in the hips. So I have a couple cases where we had to put fat in and also liposuction around these depressions to correct them. I did say that I kind of alluded to there being no great studies. There are a few small studies that I'm going to mention quickly before we finish. This one is, and I'm going to show you two that are like pro and con. This one showed that actually the longevity of these fillers in this population was better than the longevity of fat graft, which is not at all what you'd expect. 7 out of 8 patients who had fat returned to baseline, whereas the people who got polylactic acid and polyacrylamide gel did much better. This one showed the opposite, that when they measured the thickness of the fat with CAT scan, they actually increased thickness over time. So you have to believe that's stromal cells, because how else would it happen? Like I said, future fat to me is the stromal cells. When we get the key to that, we're really going to be able to do some great work with filling. You can see most of that literature is not in the United States. There's some interesting work now on improving the quality of scars with fat. This particular work was in the murine model with burn injuries, where they compared saline under these burn scars to fat, and they showed significant revascularization and significant decreased fibrotic markers. To me, the pictures don't look that great, but these really pretty pictures, they did a pretty good job of showing that they did improve vascularization and the fibrotic markers. Another sort of interesting thing is this idea that when you put fat in under skin, that it affects the skin above it. And again, I think that's got to be the stromal cells. So at baseline, this right preauricular, very sun-damaged cheek, before fat and then after fat, that regeneration of elastic fibers is going to make the skin better. And same 6 patients showing how with that stromal vascular fraction included, it actually thickens and improves the collagen. Everyone needs to read this article. That's all. We already talked about it. So in conclusion, I think fat has a role. I think it's more important off the face than on the face. I think we use fillers like fat. The line is blurred. And I still feel like there's a lot of promise in fat stem cells. I'm counting on the non-US people to do it. Thank you.
Last but definitely not least, we want to invite Roy Geronimus up, who's going to talk about ablative versus non-ablative therapies for acne scars, and recognize just the leader that he's been in laser surgery, and was actually awarded the Stegman Award from the ASDS a couple years ago. Well deserved.
Thanks, Deanna and Bill, for inviting me. Can we lower the lights a little bit? It might be easier to see some of the slides. Thanks. So there are lots of different options for treating acne scars in today's world. The options can be ablative and non-ablative, and I'll go through the various different options that one has and the considerations that one should make in deciding which procedure to use for each particular condition. So there are various different types of scars that one has to consider. You have to consider the skin phototype, your tolerance for downtime, anesthesia consideration, and the presence of active acne. So all of these factors, and I'm sure there are others, will fit into which procedure will be best for your particular patient. So the types of scars that one sees, they can be broad, they can be rolling, they can be pitted, they can be erythematous, hypopigmented, and in some cases hypertrophic. So skin types, the darker skin types, 5 and 6 and sometimes 4 are greater risk for post-inflammatory hyperpigmentation, so we have special consideration for those patients. Downtime with the various procedures, you can see wounding. So with the ablative procedure, you can get bruising, prolonged redness, bronzing, and again, post-inflammatory hyperpigmentation. So these are all things that we discuss when the patient comes in. We also are very clear about patient expectations because neither the ablative or non-ablative procedures will lead to 100% cure of acne scars. Sometimes we get pretty close, but it's important. And I often begin the consultation with the patient saying, I will not cure your problem. And in some cases, the patient will get up and leave. But that's fine, because the last thing you want is to undergo multiple procedures and have a patient who's dissatisfied. And of course, we tell them that multiple treatments will be required, certainly more with the non-ablative treatments relative to ablative, which will need fewer. So these are the non-ablative options that are available. These are all fractional right now in terms of our practice that we're using at this point in time. And the list is incomplete and growing. The original Fraxel at 1550 nanometers is now 1927. The Lux 1540, the Affirm. They're the lighter, lower energy, lower density lasers, the Clear and Brilliant and the Emerge. And now more recently, I'll be talking about the PicoSure with the focused lens as well. Well, even though you get epidermal absorption, you can get a propagation of the beam that goes deeper into the dermis. So let's talk first about non-ablative treatments. The original was the Fraxel laser at 1550 with the different columns of injury that are thermal, with areas of sparing in between. You can see the thermal effect with the areas of clearing in between and the minimal epidermal change. So by and large, these patients walk out with just some redness and swelling of the skin for a limited period of time. There's also the 1927 nanometer device that's not ablative that leaves a different histologic response. It's more of a microablation, although you don't see the wounding of the skin, although this can leave some bronzing for a short period of time. Then you have the low energy, low density devices like the Emerge and like the Clear and Brilliant. While these are very good for pigment and can be helpful for patients who have hyperpigmentation following the treatment of acne scarring, I do not find that they're particularly valuable because you need deeper energy into the skin with more of a thermal effect. So comparing ablative and non-ablative, ablative you can see on the left with complete wounding of the skin, and non-ablative on the right, where you get some redness and swelling depending upon which non-ablative device you use. So one of the best examples of using the 1550 and certainly the 1540 and 1440 non-ablative fractional devices has been with acne scarring, and this does work. I've been pleasantly surprised, and it always amazes me that you can treat these patients and over a series of treatments and see the improvement of acne scars as significant as we see. And you can see here this particular patient, and this was 6 treatment sessions. We do numb them with Emla cream for an hour prior to the procedure. This is a bit more painful than some of the other non-ablative treatments. So I will give intramuscular Toradol, and we'll use air cooling. So the patient leaves with some redness and swelling for a few days. They may get some dryness of the skin. If we add 1927 for superficial pigment, then they'll get some dryness or bronzing of the skin as well. So we've been pleasantly surprised. Initially, when we started working on this, we did some three-dimensional imaging using the Primos device. And this is a device that allows us to measure the depth of the acne scars. And we found on average an improvement of the depth of the scars after a series of treatments, which could be anywhere from 3 to 7 or 8, 50%. So while 50% may not seem significant in terms of a number, it does allow for a significant clinical benefit to most patients. And I think by and large, most patients are very satisfied with what they're getting from this particular non-ablative treatment. The downside, again, is that you have to deal with multiple treatment sessions, and not everybody is willing to do that. So here again is our operative protocol with topical anesthetic. We will give the analgesics, usually the IM Toradol, and tell the patients what's going to transpire after each treatment session. Now, the other non-ablative treatment I think is worth mentioning, we published this recently in JAMA Derm, was the use of the new picosecond laser with a focused lens array. The picosecond laser was developed for tattoos, most recently by Cynosure and subsequently by Cutera and also by Syneron. But the one device that uses something called a focused lens array is the one that's produced by Cynosure. And this is a unique lens array which allows one to get these focus beams similar to what one may see in a fractional device, and it concentrates the energy into hundreds of little microspots, which are about 20 times greater than you would get from the regular beam itself. So you're getting much higher energy, again with areas of sparing, And the beauty of this is that you're getting deep injury into the skin, but minimal downtime. So here's a young Asian woman coming in, and this is her response after treatment, and this is as bad as it gets. Just a mild erythema of the skin lasting for just a few hours. So patients who really want no downtime whatsoever, in terms of being able to tolerate just a little bit of redness, this is the go-to treatment in our particular practice. Much less downtime than the other fractional lasers that we have, and certainly very different than the ablative techniques that we have as well. So looking at patients with darker skin types, where I think there's real significant value, you can see the improvement not only of the pigmentation, but the acne scars are significantly better as well. But you can also see this took 7 treatments. Now, it's inconvenient to come to the office, but without any real significant downtime, no edema, just a mild redness, it's acceptable to many patients. Here again, you can see improvement of the overall texture of her skin. Another example, pre and post treatment. This was 8 treatment sessions to obtain this degree of improvement of her acne scars. Now, moving on to ablative treatments, you can see the histology is completely different. You get these ablative zones of injury where you're actually removing skin with a surrounding thermal effect, and you can vary this. You can go superficially or you can go deep, depending on which device you use and how you use each particular device. So the ablative fractional devices all vary depending upon the wavelength, method of delivery that can be stamped or scanning, different depths of ablation, different extent of thermal injury, and the speed of treatment can vary as well. Just some of the examples, a little hard to read, but gives you the idea that there are different devices out there, there are different wavelengths, they do have different impacts, and you really have to understand each device that you're using. The list continues to grow. We have 3 devices in our practice, but generally I use 1 or 2 that I'm most familiar with, so I can modify the technique and provide the patient the ultimate outcome. The downside, again, is this healing process that occurs. You get the wounding of the skin that occurs for a day or 2 or 3, depending upon the depth of the injury. The healing is quick. The erythema will resolve, but we do tell patients they'll have that wounding of the skin for a few days, followed by the bruising, followed by the redness, followed by the pinkness. And the redness or pinkness can last for months, and sometimes you'll have an occasional patient where the redness can last even over a year, but typically, at least for women, that can be covered with foundation or makeup. So if you look here carefully at this gentleman, one of the advantages of ablative fractional compared to the non-fractional devices that are ablative is that we can treat the neck. So I was able to treat this patient on the face and neck. Very, very nice results. This was 3 treatment sessions, wounding of the skin. I think what's unique about this outcome, not only the improvement of the scars, but the improvement of the hypopigmentation. So when I see patients coming in with hypopigmented acne scars, this is my go-to treatment for that particular reason. Here again, face and neck, you can see the improvement of the color and the depth of the scars as well. We again looked at the Primos device, looking from a 3-dimensional perspective, measuring the depth of the scars, and with this particular device, we found, this is a qualitative improvement that was noted by patients and subjects that were significant, but on average we saw close to 70% improvement of the depth of the scars. So if patients come in to see me and they ask me what procedure will give me the most improvement of my scars, and they're willing to tolerate downtime, I will advise them that ablative fractional resurfacing is the most appropriate method for them. Again, we have anesthesia considerations here. Rarely we can use topical if we're being very superficial. Most of the time we give local or regional anesthesia. Sometimes we'll give IV sedation or general anesthesia for patients undergoing procedures depending upon their tolerance for pain. So non-fractional ablative lasers, the old CO2 laser, does that still play a role? It's still a great treatment. Here's the problem. This paper that we published a while back now showing the high incidence of pigmentary loss. That's a major concern and a reason why I generally do not use this device anymore. I think patients are concerned about whitening of the skin they may have seen from this particular laser, or even dermabrasion or deeper chemical peels. Here's an example of some whitening of the skin that occurred over the long term as the patient was exposed to sun. You can see a dramatic transition. So we generally avoid non-fractional ablative devices. So how about patients with active acne? This is a problem. I used to send these patients away. I would say, go back to your dermatologist, get your acne under control, come back and see me, and then we'll deal with your acne scarring. More recently, we've been using a high peak power YAG laser. at 1064. The XLV in particular, about 50 millijoules, a series of treatment sessions. We improve not only the redness of the skin, but the texture of the skin and the acne both tend to resolve simultaneously. So this is something newer in our practice and has been a nice adjunct in terms of being able to treat those patients who have both active acne and active scarring or acne scarring at the same time. So in summary, acne scars are very heterogeneous, presenting in a variety of clinical conditions. You have to speak to each individual patient, find out what their tolerance is, find out what kind of downtime they want, advise them what is best for them, and mix and match the particular procedure based upon the technology that you have. Minimal downtime, I prefer the non-ablative fractional or the picosecond laser. Deeper scars, ablative fractional. Darker skin types, the picosecond laser with the focused lens again. Hypopigmentation, ablative fractional. If there's erythema, I'll add a PDL or IPL can be used as well. And the presence of acne, using a long pulse YAG laser. Thank you very much.